Healthcare and Financial Services Subcommittee held a hearing where we heard from the Trump administration about the youth healthcare crisis. Not only are our children facing chronic diseases as rates never seen before, but the healthcare system seems to only get more expensive without any noticeable improvement in outcomes. Recent data published by the Trump administration and confirmed by several other independent sources indicate that 1/3 of healthcare costs are wasteful and don't improve patient health. We're going to throw it. We'll start with Mr. Jacobs. Why are 1/3 of healthcare costs wasteful and fail to improve patient health? Do you believe that's true?
I certainly think there is a great amount of waste in the healthcare system. Unfortunately, we, as I mentioned in my testimony, we don't have correctly aligned incentives. Everybody, if you know, the traditional example is the all-you-can-eat buffet. Everybody does a good job of spending everyone else's money in healthcare. Now, obviously, there are circumstances you're not going to, you know, try to shop for care when you're in an ambulance on the way to the hospital or anything else like that. But we do need to realign incentives at the margins to show where people can be smarter shoppers of healthcare. But first, that requires price and quality transparency. I've had personal difficulties myself on numerous occasions finding out what the heck things cost.
I'll give you guys another question, and anybody can jump in here. Utilization rates vary from doctor to doctor and state for state. Does anybody want to comment on that or have any information on examples of overutilization, which would indicate that more is being spent than has to be spent?
Well, Chairman Grothman, one issue is that if you look at that variation from state to state, it tends to be greater in Medicare than it tends to be in the commercial insurance market. And I think that indicates that when there's oversight in terms of what's valuable care, it helps to mitigate overuse. Examples of overuse, a prominent one is what's known as defensive medicine. So it's testing that's undertaken because of malpractice risk. It probably adds, our research suggests, around 10% to medical spending. So that's one important source as well.
Okay, and that varies from state to state?
It does, yes.
Can you give examples of a high state and a low state, or just a shot at a specific example of dramatically higher costs in one state than another state?
Typically, the states that award higher jury awards in malpractice cases tend to have more defensive medicine.
Okay. Yeah. I think we can all agree we have a problem when 1/3 of healthcare spending, according to some people, goes to waste. Can you explain why that is such a problem and how it affects the healthcare market? Mr. Worley, I guess we'll start with you.
Yeah, healthcare costs are a combination of the volume of care we seek and the prices we pay. Enabling people to pay the price and enabling more and more cash prices and direct prices for there to be a single price for all versus a single payer for all, enabling people to actually know what the price is ahead of time, the real price, that intermediaries or AI can't reprice. That's important to enable patients and employers, purchasers of care, to give signal, is it the right price? I think it's important that in terms of the volume, whether there's overconsumption, there's also underconsumption in the market as people are unable to pay for care. That's why nearly 30% of ACA markets have built solutions like patient into ACA plans to ensure that people are able to get care when it happens, because healthcare is a necessity.
Okay, what I'll do is I'll go down the line starting with Mr. Lakdawala. How have you personally experienced rising healthcare costs in your individual field or from the perspective that you're in right now? And specifically, what would you like to see Congress do to rein in those costs?
I would like to see attention paid to measuring the value of different healthcare procedures, drugs, devices, and the like, and ensuring that we're not continually investing in low-value care, which is happening. For example, most Americans say they don't want to die, they don't want to spend their last days of life in a hospital, yet a majority of individuals end up there. That's wasteful care because it's not aligned with what patients value and their families value.
In other words, people are, well, we'll go ahead. I'm running out of time, so we'll go down the line.
I'll just tell you one fact from my own experience as a physician. I've ordered a lot of wasteful tests, for example, in the ER, tests for heart attack that expose patients to risk and costs and come back negative. At the same time, heart attack is one of the most common reasons that doctors get sued because we miss it. And so even though, of course, there's a lot of contribution from incentives, fear of malpractice, the core of the problem, at least from my perspective, is that it's really hard to make decisions about who needs care. And I think that's why I'm so optimistic that artificial intelligence can help us make better decisions and thus reduce the cost of care, but also improve the quality by taking some of those costs and giving it back to patients who need the care.
Mr. Jacobs?
As an exchange customer here in DC who's facing a premium increase starting next month, I certainly understand the cost because I have to pay all of those out of pocket. I'm self-employed, so I don't have an employer to subsidize. I actually agree with Ms. Tripoli. I think site-neutral payments, and there's a good amount of bipartisan agreement on this, is a good policy that Congress should be enacting. I just recently went to a specialist for a second opinion on an orthopedic issue, and I ended up paying twice what I normally pay at my usual specialist, primarily because the second opinion was affiliated with a hospital, and it's a physician office visit, but it's billed through a different service. It's billed as an outpatient clinic visit, and so I pay twice as much. We shouldn't be inviting these kind of disparities, and that encourages more physician practices to merge with hospitals because they can charge more.
We're going to break the rules and ask the final question to Ms. Tripoli, the Democrat witness.
Well, I actually agree that the underlying incentives, the payment incentives of the healthcare system are misaligned. All the incentives are to get bigger and bigger and to charge more volume of high-priced services rather than making sure that people are getting the high-value care that they need to get healthy and stay healthy. And so I do think that there's a longer-term conversation about how do we structurally realign incentives with the health and financial security of the American people. But I will tell you that it's very hard to have that conversation when you've got 22 to 24 million people right now who need the enhanced premium tax credits extended. And so that's the lifeline that I need today. And then I encourage Congress to have a conversation about how to realign payment incentives in the healthcare system.